to our patients, like Vincent, and indeed to others, we find that our treatments may not be as well tolerated as we thought. And this is just some of the stuff that's out there. We all think we're doing a great job. There are others that are challenging that. And it's our duty, I think, to listen to it and indeed to respond to it. Even our fellow professionals are accusing us of over-treatment. And in this article, Anthony Zeitman said that the principal determinant of your therapeutic allocation was in your back pocket. Which is quite an accusation in a major journal, JCO, by a very respected oncologist. And then we had the kind of kick in the teeth. I think you spent all yesterday discussing this with Peter Albertson, which again is telling us, in the best evidence base possible, that our current testing and treatments are conferring no overall benefit to the patients that we treat, but a lot of harm and a lot of cost. If you look at Welch's thing in JAMA just a few weeks ago, he was saying that the 1 in 1,000 possibility, at best, of reducing your chances of dying if you're screened for 10 years and treated versus the boatload of worry, harms, hassle, long-term side effects that you may have to endure for life was just a very bad deal. And so I think we can either ignore that or we can respond to it as responsible professions to address the issues of harm, which we've just started to do. And I think that's the challenge for the next decade. But we need strategies with which to do that. I'll come back. And this is just about to hit us as well, isn't it? This is just a second reminder that currently all this work we do is probably conferring very little in the way of harm. This hasn't been published yet. This is pivot, hence the nature of the studies, but no overall reduction in survival of either prostate cancer specific when you compare radical prostatectomy, not to brachytherapy, not to radiotherapy, but to nothing, right? And this will come. This will hit us. It'll get a lot of press. And again, we will have to respond to it. And if we're going to treat people with such small margins, we have to do so very safely and in a very well-tolerated manner. So, what are the challenges? To establish a threshold for clinical significant disease, so the benefits, if any, on pivot were in men with a PSA of over 10. So there are some men we all accept don't need treatment. Avoid diagnosing insignificant disease. There's no merit in diagnosing something that isn't going to benefit from treatment. Get better at diagnosing significant disease. A lot of people with significant disease slip through our fingers. That's a different talk, but it's very important. And the basis of this talk is really to address the harms and, to a degree, the cost of treatment. If you confer harm on somebody, it costs. Lifelong incontinence requires pads, social changes, and possibly further operations. And these things matter. This was a very interesting study just published, and men are willing to trade life expectancy for harms. So if you have severe urinary leakage, men, when asked, need at least 2 years of life, of extra life, to compensate for that burden. This is a very important study. And these are individuals, so if you have more than one harm, you can add these up. So if you're impotent and incontinent, the treatments that we currently confer on our patients have to confer an excess of maybe 2 or 3 years. Remember, currently our treatments don't do that. So what we have to do is avoid harm in nearly all patients if we're to carry on doing what we're doing. So this is just a strategy. I don't know if it's right or wrong, but it's the strategy we adopted in the kidney. We used to treat all kidneys the same. It used to come out irrespective of burden or location of disease. Now we regard that as crazy. Penis, we used to chop off penises. Now we do selective therapies for penile cancer, penile preservation. So can we do the same in the prostate? Can we treat selectively? Can we treat men in a different manner? Can this man avoid, and you spent, I think, all day yesterday, so you're experts now, there's his tumor on the gadolinium sequence. Could this man be watched? Could he be biopsied? If biopsied, there's no point in doing kind of 12 cores. What you want to do is oversample this area and undersample the rest of the prostate. If you think he needs treatment, and this has significant disease in it, could you just selectively treat that lesion? You can see the lesion there, and you can see the ablation just there. And if you do that, can you preserve function and indeed reduce cost? That's a question. And indeed, you can do that with radiotherapy, CyberKnife, TrueBeam, Brachy, HDR, electroporation, HIFU, cryo. It doesn't matter. The only thing you can't do it with is surgery. So with cryotherapy, this approach has been successful. If you cryoablate a whole prostate, all men virtually are impotent. If you preserve a little bit of tissue, you can change the health status from 10% to 70 or 80%. This is a dramatic difference in health status as a result of just holding back a bit and preserving a bit of tissue. This indeed is the proof of concept. And just look up here now, although there aren't many patients here, the number of patients being treated with cryo in a prostate-preserving manner is now the dominant form of therapy. And this number is going up all the time. There's a paper about to appear in European Urology showing a 99% freedom from recurrence in the treated group with about an 80% preservation of erectile function and zero pad-free continence. Sorry, 100% pad-free continence rate. So this is happening. This is our own, this happens to be HIFU. We use about 4 technologies to treat selectively. And this just shows the way that we were from whole gland, which I don't think is a viable option. There are much better ways of treating the whole prostate, such as surgery. But this is our focal therapy platform now. And we're treating about 150 to 200 patients a year now using this form of technology. And this is the evidence that is accumulating. This is an experiment, and the experiment is not over yet, but the initial signals are very strong. So this has been published now in JUROL. This is to be published next week, I think, in Lancet Oncology, or very, very soon. And again, showing almost a virtual guarantee of potency and a virtual guarantee of drip-free, pad-free continence by questionnaire. So I think we don't need much more data. We need to know whether that's sustainable. And then I think we also need to know about retreatment rates, about salvage opportunities, and also the medium-term oncological outcomes. The long-term oncological outcomes will take 15 to 20 years to be established. I don't think men are going to wait that long, and I think we'll just have to assume, like all other therapies, that they're probably equivalent or so small as to be impossible to analyze. These are the kind of approaches. This is the entry. So this is the hemiablation where you insist on no known disease on the other side, but of course that's a con most of the time. Because your biopsy is negative doesn't mean they're negative, and you treat the disease. This is how most focal therapy is done. This is our second study, which is going to be in Lancet Oncology, in which you define a bespoke treatment to treat several foci, if several foci are present. If one is present, you can just treat that. And this is the most interesting biologically. This one here, let's go back one. This is where you actually accept that small foci of Gleason 3+3 don't need treatment. You can't rule them out, even if your biopsies are negative. If you find them, just leave them, and you treat the dominant disease. And this study is still recruiting currently. This is an example of a true hemiablation. There's a tumor. There's the gadolinium sequence there. That's the hemiablation. You take out half the gland. These are day case treatments. Come in the morning, go home about 3 hours later. And this is a bilateral treatment. He's got two cancers, a big one here on the edge, and then another one just in here, not very clearly visible. And we combine the treatment to ablate these zones to cover that area. But both neurovascular bundles will have been preserved in that man. And so this is not just about treatment, it's about changing the way that we diagnose these men. So holding back on biopsies in men that you don't think need a biopsy, and maybe biopsying different in men in whom you see a lesion. You can't see it very well here. There's the T2 image, there's the gadolinium image, there's the diffusion. This is a cancer. Without the MRI, you could have missed it on biopsy. With an MRI, you may choose just to watch it or to oversample this area and undersample the rest. And how we do that sampling with registration, different biopsy strategies, I think is another lecture, but a very interesting one. This is the result of the first proof of concept study. 18 trifecta, if you believe in trifecta, just summarizes the data well. So 90% of men free of disease, pad-free continent, and erection sufficient for penetration, about twice as good as the trifecta rate on radical prostatectomy. This is the study that will appear in Lancet Oncology, very similar, a return to baseline genitourinary function. Slightly worse erectile function, 84%, and I think that happened because we went across the midline. So in some of these cases, and obviously there's a limit to how much prostate you can treat before you start affecting erectile function. We don't know what that limit is yet, but clearly I think we're seeing it there. And I think we're getting into medium-term data now. So all these patients that go into these small, short studies go into a registry, and we're following them up, and we're starting to see. So these two trials are completed. We're still waiting. All these men have been treated, but we're just waiting for the final patients to be completed. And all these kind of difficult outcomes are being measured, and I think suffice to say that the initial results that I just showed you are being maintained to a very large degree out to 2 to 3 years. Very low rate of salvage requiring radiotherapy, lower than you'd have after surgery, for instance. And these are the kind of outcomes that you're getting 3 to 4 years after treatment. So, you know, the short-term outcomes look good. The medium-term outcomes are holding. We need more numbers. We need some form of large phase 3 randomized trial. Before we get that, we've got to go multi-center and show that expert centers aren't unique or odd or different, that these things can be easily reproduced elsewhere. This is recruiting well at present, which is the first phase 2 multi-center site of HIFU treatment, allowing low-risk disease to remain untreated. You can see the disposition of the study there. This takes a medium-term view and rebiopsies men at 36 months with a big biodiscovery channel running alongside it. And essentially, to address the first stuff of my talk, the focal therapist doesn't want to treat this either on its own or in conjunction with this. We're doing a lot of work, a lot of effort to identify men with this type of disease and then focusing our treatments to this type of disease and leaving this well alone, because I don't think there's much benefit to be had in that area. So let's just move on. So that there's other, this is not a HIFU talk, this is a focal therapy talk. Radiotherapists are already looking at this. This is a phase 3 STIBA talk. Many of you are involved in this. This is recruiting quite well, but 87 patients recruited to a 400-patient study. Low-risk patients, probably the wrong population to treat, but nevertheless, that was what was required from the regulatory agencies. This is the kind of result you get, hemiablation on MRI afterwards. This was a group of brachytherapists. We all met and this has recently been published, just to show how you can use brachytherapy, if you know location, no burden, to change your plan, to improve efficacy. In other words, increase your dose to the tumor, but at the same time decrease your dose to the urethra, rectum, nerves, and bladder. And I think this is the next 10 years in terms of planning. It might be very simple. It might be, where's your tumor? Hop up onto my couch, and you'll inject Protox or bleomycin or something straight into the tumor, and you'll just say to the patient, off you go, see you in a year. It may end up being as simple as that. It may end up being as complicated as having to use a cyberknife, forcing the beam onto a fiducial marker or indeed a GPS thing. I don't know. I don't know. And I think we can speculate. This is using Visualase, which is FDA approved and running in various private centers in the States. So I think it's happening. This is going to happen. We're through proof of concept. We're through phase 1. We're through phase 2. We're into phase 3. And I think the challenge is whether we can actually pull off a pragmatic focal therapy study against the standard of care, whether men would be willing, when you present them with such extraordinary functional outcome, whether they'd be willing to be randomized to other areas. And that is an experiment that we need to do. So I think I've summarized this already. But remember, this is going to change not only the way we treat, but it's also going to change the way that we work up our patients in terms of our diagnostic strategies. Thank you very much.
Thank you very much, Mark, for this new way in the future. Yes, Professor Yuneman. Yeah, just.
How do you identify? I'm much interested in the last study you're doing, the last one where you're still recruiting. How do you identify the index tumor?
So MRI, and in that group, template-guided biopsies. But the next study we'll do won't involve templates. It'll just be a targeted biopsy. We'll trust in the radiological phenotype and the negative predictive value of MRI. If you biopsy, as you know, if you biopsy negative MRIs, you find nothing. Yeah. You find a little bit of Gleason 3+3. There's no point. It's a waste of time. So I think that all our studies are getting more and more pragmatic. You know, the first studies were very rigid, as the world would expect, and now they're getting more relaxed. And actually, reviewers, ethics committees, patient groups are allowing us to have a much more relaxed view of this.
What about your studies you're doing with the histoscanning for tissue characterization?
I haven't mentioned histoscanning. Histoscanning's in every study as well as MRI. So we collect the 3D volume file before the biopsy. So that would be used as part of the biomarker discovery.
Thank you.
Franz?
You have a high rate of potency, about 93%. I could imagine you make a HIFU on one side and the peripheral zone of the prostate, and you can spare the interfacial nerves. How does it go?
Well, I don't know. I don't know what we're preserving. Just like a surgeon doesn't know that he or she has preserved nerves. It's an intent to treat. Yeah? You don't know. There's no test that you can do. You don't. There's no test that you can verify. So I make no assumptions. I'm just quoting you outcomes. If you preserve tissue, you preserve function. I didn't know that before we did this. And if you just treat half the gland, doesn't matter if it's cryo, it doesn't matter what you do, most men, 70% get their erections back within 2 weeks, and then at 6 months, I think, 95%. There's a statistical return to baseline. So what matters, I can't say anything about the treated nerve. What matters is that the other nerve isn't getting treated or damaged, whether it's a neurotomesis, neuropraxis, or some kind of heat injury.
And you are true that you are near enough to the peripheral zone in the cancer. Yesterday we had a presentation from Italy where the nerves can stimulate it and seen in this corpus spongiosa and so on. This operative procedure, we can see it. I give you the paper from yesterday.
No, I'm fine. I accept that. I'm not going to argue about that.
Mark,
yeah.
Really nice talk. We presented at the EAU, and then I presented 2 days ago our autopsy data, Caucasian Asians, and actually just referring to the fact that you said in the future you only will biopsy the main lesion, if I understand correctly.
I think that's what
we found a lot of Gleason 7, 25%, 50% in Asians, which already is a little bit intriguing. But what seemed to be the difference is that on autopsy, most of these studies, most of the lesions were unifocal. So 75% of the tumors were unifocal, even if it was Gleason 7. So aren't you afraid that actually by not biopsying or going in the trend that I hear more and more, you may just miss the indication whether something is multifocal, and that could be actually a prognosis. I have no answer. I'm just asking whether you're taking
the negative predictive value for MRI for clinically significant disease is 95%. The negative predictive value for trust biopsy for clinically significant disease is 20%. So MRI currently is 5 times better than trust biopsy at ruling out clinically significant disease. So I think we've just got to it'll take a while before we trust imaging. And imaging is difficult. It's not everybody's got access to good imaging. But, you know, no test will get everybody. But MRI will result in false negatives much, much less often than our current standard. There's a big systematic review coming out of image-guided biopsies, right, which is what we do in every other cancer, every single other cancer, versus standard transrectal biopsies. And it shows superiority and greater efficiency in all aspects.
Yeah, but maybe that Gleason 7, 3+4, accompanied by something which is not picked up by MRI, but which is microscopic and multifocal, maybe, I don't know, is different from a single Gleason 7, 3+4 without. I mean, I'm just saying that you miss part of the information.
I didn't pretend to know what clinically significant disease was.
I don't really even know.
Yeah, but I think I think actually having some visual cues as to where the maximum burden, all other cancer models are driven by volume. You know, we just haven't known volume in prostate cancer yet. So, so we have to rule out volume, I think, as a predictor.
Okay.
I don't want to be accused of running over my time. Yeah. The catheters are removed. We put a suprapubic in. This is focal therapy, all right? I think it's important to move on from the technology, which is secondary, to the concept, which is primary. Most men avoiding the next day. We put a suprapubic catheter in, and then they phone us and we take it out. IPSS improves. So the 3-month IPSS after focal treatment is better than baseline. Incontinence doesn't happen, you know, 99% pad-free rate.
Last question from Professor Wiegel.
You said that the negative predictive value of the IMT, of the MRI is quite important. That's correct. But there is no prospective study that shows that it will hold in the future. No data about this. What's 1, 2, 3 years later with a negative predictive value? Perhaps the cancer then will appear.
Then if the test performs at that rate, it should pick it up. I mean, the RESIST criteria is based on that. So you apply a test to a patient with a cancer. If the cancer changes radiologically, they're progressing. So MRI is the within-patient variability of MRI is very, very high. If I do an MRI on you today and tomorrow, it'll be the same. What we don't know its responsiveness yet. So in other words, if I have an MRI and it's normal, and I have it again in a year, and I develop a 0.2 cc lesion, what's the chances that I'll pick it up? We know the specificity and sensitivity of MRI at 0.2. It's 75, 86%. So I think it's a test that you're just reapplying. I don't see it as a problem.
Okay. So I'm sorry, but I think that we have to move on now for the next speaker.